Depending on what hospital you work at and what brand they use, you might find different things in the kit, but it's basically going to be the same stuff no matter where you're working. As I said, it is an aseptic procedure. When you open your kit up,
Do you wear gloves, man? Oh, those are the gloves. I'm sorry.
that's okay.
So busy recording, I can't see what's in there.
You have a basin in here that you're going to use to put your sterile water or your sterile saline in to rinse your catheter. This is your basin. It's right on top. When you take it out, be careful not to touch the inside of it because, as I said, we want to maintain asepsis. You can go underneath and open it up. Place it down. You have your pad of sterile gloves in here, as well as your suction catheter. It's all in a sterile field right there.
And what's the basin for?
You're going to put water or saline in there to rinse your catheter. It will tell you right on the front of the package before you open it whether or not you have the cup and the gloves inside your kit. Most hospitals make sure that they have kits with 2 sterile gloves. You may on rare occasion find a kit that only has 1 sterile glove. If that be the case, please make sure you put a glove, an unsterile glove on the other hand for your protection. You'll see why in a second. But they try to get them with the 2 gloves. They will also tell you right on it what size catheter you're using. This one is a 14 French. Now that I have this open, the things I'm going to do first. First, I'm going to pre-oxygenate my patient. If my patient is not on oxygen when I go in to suction them, one of the first things I'm going to do is I'm going to go to the equipment room and I'm going to get a non-rebreather and put the patient on a non-rebreather. I'm going to turn it on. After I tell the patient I'm going to be, cleaning out your airway. I'm going to have to go down with the catheter to get the mucus out because you're having trouble, coughing it up. I'm going to put oxygen on you for a while because you always need to pre-oxygenate your patient. When you start looking at the hazards and side effects of suctioning, hypoxemia is a very big one. The most serious side effect of nasotracheal or endotracheal suctioning is death. You can actually cause
Vagal, right?
vagal stimulation, which can cause bradycardia, but it can actually cause death.
And that's when patient was just on room air and they couldn't cough it out, so you put them.
Right.
How long do you put them on the non-rebreather mask?
You're going to I usually just put them on before I start. And then the whole time I'm setting up, they're going to be on that oxygen.
Okay.
If your patient's on a nasal cannula, you have the option of putting the non-rebreather, taking the cannula off and putting the non-rebreather on. One of the things you may see some therapists do is they'll put the flow up a couple of clicks. And remember, as you turn the flow up, you're also increasing the FiO2. And then you're going to put both cannulas on the one nostril so they're getting oxygen the whole time. That's an option. It's not the preferable option. The preferable option is to use the non-rebreather. Okay, so I have my patient oxygenating while I'm getting my equipment ready. I've opened my kit. I'm going to get a brand new bottle of sterile water or sterile saline. And I'm going to pour that into my cup. If you open your brand new bottle, please be certain to date it. Because if somebody comes in 3 days later and this bottle is still here, it's really terribly contaminated by then. You're going to date it in 24 hours. You're just going to throw it out and get another one. I'm also going to open a package of sterile Surgilube or some kind of lubricating jelly. Please be certain that you're using a water-soluble lubricating jelly, like a KY jelly, Surgilube. Never use a petroleum-based product like the A&D ointment or Vaseline. Always water-soluble.
The kit comes with it?
No. You have to bring that in with you. That and the saline you have to bring in with you. They don't make it that easy. You serious?
Only in the cath kits.
Okay, and then I'm just going to open that up, and I'm just going to put a glob down somewhere. Notice I have yet touched anything on this field with my hands, with my unsterile hands.
Where did you put the
Right on the.
Yeah, just right on the paper. Oh, who's playing with these things?
A man and a lady.
What would you put the patient on oxygen level, like if they weren't already on? How high would you?
I said a non-rebreather.
Oh, non-breather. Hello. I know.
That's okay. When you wake up, well, you can come back and see.
That's almost as bad as Alyssa.
What?
Where's the glove?
Where's the gloves while I'm staring at them?
If the suction is not on, come over and you're going to turn on your suction. You're going to turn up the pressure. Now, if you're suctioning an adult, your book tells you 100 to 120. This is negative pressure, so that's a negative 100 to 120 millimeters of mercury. Turn it up, check it to make sure it's working. If you'll notice in a lot of the hospitals, are you kidding me?
Marion, where do you find the gauges? They would be in the equipment room?
Say that again. These
The
are always hanging on the wall.
The
Or they
pressure
should be.
gauges?
If they're not hanging on the wall when you go into the room, then it should be in the equipment room. If it's not in the equipment room, you get on the horn and you call Central Supply.
I've never seen one in a room. Have you?
What?
The pressure gauge like that? I've never seen one in a
It's
room.
usually just beside the oxygen.
Have you looked for it?
Yeah, I mean when you're doing
Probably only a certain
It
floor.
It
like
should
that
be on the
floor or
wall. You notice on the wall, when you look at the wall, you will see your green for oxygen, you'll have your yellow for air, and then you'll have the white. That even if there's not a gauge up there, that's where it goes.
No.
And it's the DISS system, so nothing else will attach to that. And as I said, if it's not on the wall and you've been called to suction the patient, you can just ask the nurse, do you have suction gauges on the floor? And she'll tell you where to find them. If they say they don't know and they don't have the remotest idea where to get one, you get on the horn, you call Central Supply, they'll ship you up one.
Okay.
Okay, before I get any further, just let me talk about that. I'm glad you brought it up. Okay, this is your gauge. As I said, it's a DISS, goes right to your wall. You have it calibrated in millimeters of mercury. Your suction canister. It's a disposable. Once it's filled, it's got to be tossed out. Inside here, you have a float. Once liquid touches that float, it absolutely will not allow you to suction anymore. In other words, if this thing gets full and liquid touches that and you go and you start to try to suction your patient, you're not getting any vacuum, and you look over and this thing is full, you have to empty it. Now, these days, they're disposable. And as you can see, you have all these little caps that go on all these openings. You simply cap it up and you throw it in the garbage.
Fire hazard?
Unless the patient, there's blood in it or the patient has a disease process, it doesn't have to go in biohazard, it just goes in regular garbage. And then you have to go into one of those medical vending machines and get a new one.
How long does that take to fill?
Depends on how often the patient has to be suctioned.
How long would you let that sit there? Because that's kind of gross.
It sits there. It sits there.
It sits there for a while.
Yeah,
Until
it
the
sits there
patient
for a
leaves
while.
and you have to clean the room for
Because
the
I-
next patient.
Yeah.
I always change
I'll
the
be the
canister.
therapist that's wasting and throwing it away when it's like not even half full.
And this is a shared responsibility, again, between you and nursing. If you go in the room and you see it's up to here, even if it's not full yet, empty it. Get rid of it and put a new one in. If she sees it first, she'll get a... Or
You have
he-
to chart it, no? Or no?
No, you don't have to document because you're just throwing away waste. Okay, it usually goes on the wall, and as you see, you have all these little ports, and it tells you right on here what goes to where. Like this one goes to the patient, this one goes to your vacuum.
The tall one's
So
the
you see
vacuum,
it
the
comes
short one's
from your
patient.
vacuum. You have a small tubing, which goes onto the center one here. Now this one, you may see some in the hospital where these ports are in a slightly different position, but same applies. You can find suction tubing anywhere in the hospital. It usually comes in a package all wrapped up. You just open it up, and again, you attach it to the port that says patient. When you turn your suction on, your gauge goes up, and you just want to check to make sure you have vacuum. Because a lot of times what happens is you'll go in, you'll get everything ready, you turn it on, you do this, and you have no vacuum. That's because either this is full or one of those ports is open. And you're not, if I open one of these, I'm not getting any vacuum. So that's just a matter of you troubleshooting your equipment before you do anything to your patient. Making sure
What are the other
everything is
two
working.
ports next to it for?
This one, it used to be back in the day that you would actually pour it out down the sink and use it. But the port's still there, but we don't do that anymore, thank God. And the other one, you can actually have 2 suction ports hooked up. So, my suction is on. I've checked it to make sure that it's working. My patient is being hyperoxygenated. I have my sterile equipment laid out. And now you remember that checkoff that everybody hated with the sterile gloves?
Yes,
It's
same
coming
thing.
back to haunt us.
Remember I warned you it's going to come back
Yep.
to haunt you? And I promise you that every single one of us will fail you on the spot if you contaminate the gloves. Yeah, put it on back.
So you're allowed to touch that whole edge that's
The
folded because it's the
inside.
inside.
Yeah,
Yep.
you can touch this. And you're going to go under just like you did the first semester.
Clean to clean.
Now that I have my gloves on,
Now you can touch.
I have to decide which is going to be my clean hand and which is my sterile hand. Since I'm right-handed, I like to do the actual suctioning with my right hand, so this is going to be my dirty hand, which means I can touch everything else. With my dirty hand, I can only touch the suction catheter with my clean hand.
You know what I used to do? I used
Huh?
to make a fist. With whatever hand was my sterile hand, when you're doing stuff, just put your hand in a fist. It works.
Then you remember?
'Cause then
You don't
just-
use it.
You just put your hand in a fist when you're doing stuff, and then you won't open your hand, because you will. You'll
Good idea.
realize that you'll do something, and you'll be like, and then it's all over. So I used to make a fist and then do everything.
That's this.
Try it.
Now, when you take this suction catheter out, make sure that you keep it from, you don't want it dangling, because if it accidentally hits something, it's contaminated. So you just want to have complete control over that catheter. I can touch this part with my dirty hand, but only the suction catheter can only touch with my sterile hand. I can now attach these two. And this is my thumb port. Okay.
And now that the other side is already contaminated, right?
Yeah, this hand is contaminated because I touched that tubing
Dirty.
with it. I can pick up some Surgeon lube because anytime you're going to go down, you want to make sure that you're not going to cause trauma to the patient's airway. So a little lube. Again, I'm going to completely control this catheter. Tell my patient again what I'm going to do. I'm getting ready to suction. I'm going to go down your nose and see if I can get all this stuff out. Now, I don't personally like taking the mask all the way off because then you have to get it back on again without using your sterile hand. I like to bring it down here. 2 reasons. 1, it's easier to get it back on the patient's face. 2, you're not totally depriving your patient of oxygen right now. So, without applying suction, the only way you're going to apply suction is when you hit the thumb port. As long as that's open, you're not applying suction. So, with my thumb port open, I'm going to very gently advance this catheter down the nostril. If I hit resistance, I can kind of twist it and see if I can get around it. If I still can't get it down, I'm going to come out and go down the other side. They may have nasal polyps. They may have a deviated septum. You don't want to force.
Once you went down one nostril, you're allowed to take it out and go into the other one.
Mhm.
It doesn't have to be a whole new clean one.
No.
Okay.
I'm going to go down as far as I can get down there. Now, you also want to, if you can, have the patient open their mouth, because sometimes if you don't hit the right area, it can coil up in the back of the mouth, or sometimes I've even seen it come out the mouth, so you want to make sure you're not in the patient's mouth. You're going to eventually hit resistance. You're going to stop, back up about 1 centimeter so that you're not right on any mucosa, and then you're going to apply intermittent suction. That means I'm now coming on and off with my suction, with my thing. Notice I did not apply suction as I'm going in, only as I'm coming out. Intermittently, kind of twisting this catheter for 15 seconds only. After you're out, immediately reoxygenate. Give your patient time to recoup. They may be coughing. If they're a little bit conscious, they may be coughing, they may be gagging, they may turn a little red on you. Their heart rate's going to go up. Unless you hit the cause vagal stimulation, in which case their heart rate's going to go down. Their blood pressure may go up a little bit. If they have a problem with blood pressure, you have to be concerned about intracranial pressures. So a lot of things you have to be concerned about when you're doing this, but it's a necessary evil.
And you don't necessarily have to do the other side. If
No.
you got enough on the one side, you're done.
You can go down a second time, because remember, it's only 2 holes only so far, then it becomes 1.
Right. So you're getting it regardless.
Right. What you're getting is the stuff down here. If you feel that maybe there is something in the other nostril and you want to try to get it, you can do that. You can even go from nose to mouth. If you think there's something in the back of the patient's mouth that you
Oh,
need
just
to
to the
get
back.
out,
Okay.
you cannot go from mouth to nose.
The nose is cleaner.
The mouth is the dirtiest part of the human body.
Okay.
The nose is a direct pathway to the lungs, which is themselves a sterile field.
Because it's filtered.
So you can go from nose to mouth. You cannot go from mouth to nose. If you feel like you need to go back down again, you can. Every single time you come out, immediately reoxygenate. And now you can just use this to clean any mucus or gunkus inside the catheter out. That's why you poured that in there.
And
Okay.
you're holding that, yes.
Yeah.
And then do you put it back into the lubrication?
If your patient is very, very dry, you can relube it. But usually by the time you get all that mucus in there, it's lubricated enough.
Now, is there only a certain amount of times you did it once?
3
You do-
times is the preferable. Your book will tell you that you should only do it 3 times. There will be those instances where you may think, I really need to go down at least 1 more time, but you're going to give your patient extra time. to
Time
recoup.
with the, yeah.
Always have your patient in a semi-phallus position. I forgot to mention. It's preferable if your patient can't sit up, if they have like a spinal surgery or something, okay. But if it's at all possible, put them up into semi-phallus before you suction.
Does that keep their airway open? Is that why?
It doesn't keep, well, it does, because the tongue doesn't fall back, but more importantly, it helps them to breathe. Remember, the diaphragm
Okay.
works better when you're in an upright position. You get more air into the lungs. It helps them to breathe. It helps them to cough. And if they can cough a little bit of it up to you, that's great.
So if you said you can do it up to 3 times, but no more than 15 seconds per.
No more than 15 seconds per pass.
Okay.
Right. One of our instructors used to say something like, well, hold your own breath. When you can't hold your breath any longer, you've been down there too long. But if you can hold your breath for 30 seconds, you've still been down there too long.
Yeah,
So
yep.
that doesn't really work. Sometimes you have to get a sputum sample to go to the lab. They come in a package like this, which means when you open it up, it's also sterile until you open it and take it out of the package. It's just, this one is just called a sputum trap. Let's just get the other names on here. No. What you're going to do is, the suction catheter goes through this rubber part here, and this part goes down here. Oops.
Now, if that happened in the hospital setting, would you have to get a new tube?
This took, as long as it didn't hit the floor.
Now, is that hand still considered
No,
sterile?
it's going to be sterile when I take it out of the package.
No, your hands.
Which hand? Well, if it's sterile when I take it out of the package, then I'm still using my sterile hand.
Okay,
But this one doesn't have to be sterile. This can touch this part.
But you can't touch the cup with that hand, though, right?
Not if it's not still in the pack. When you first open that package, that's sterile. You can touch it with both hands.
I got
So you should open that package before you pick up your tubing, because
thinking
then you
of
can't
the
put the
sample.
tubing down to pick up the
You're
package.
not going to put the tubing down once
Yeah.
you get it in your hand, right?
Okay.
If you know you're going to get a sample, you're going to do that first.
Okay.
Okay.
So then you're just going to do everything we just did. Please make sure you keep this straight up, because if you haven't, let me just show you what when you suction the patient, your sample now goes into here. If you inadvertently do this, it's going to get suctioned right out of the cup and you're going to lose your sample. Once you're finished, you just fold this over. Put some tape around it, label it, just like you would a blood gas. You know, the room, the patient's name, the date, that it's a sputum sample, the patient's ID number. You don't not necessarily always know what the sample is for. Usually the doctor will tell you what the sample is for, but it's not necessary that you put that on there, because that will be in the computerized sheet, label that comes up.
I'm confused.
And now you want to just put this in your hand without contaminating yourself. You're going to pull the glove down over it so that now all of that contaminated mucus and gunkus is trapped inside here. And it's not going to be, all over the room and stuff. Your patient is oxygenating some more. You're going to do your post-assessment before you leave the room so that you can document everything you just did. One thing that I forgot to mention, and it's extremely important, is suction is not one of those things that you just automatically do every 2 hours, every 4 hours. The doctor may write every 2 hours, but they usually will write every 2 hours PRN. That means every 2 hours as needed.
Not scheduled.
Huh?
Suctioning is not scheduled.
So that means you do not just go in every 2 hours and automatically suction the patient. You're going to do an assessment. Does the patient need to be suctioned? Listen to breath sound. That's the only way you're going to know. Patient has a cough. And please, if you listen down here and you hear stuff, this suction catheter only goes to the carina. You're not going to get, if you can't even get down here with a bronch.
So it would only be what you hear in that.
You want to hear what you hear up here, where you can actually get to. So make sure you assess before you suction. And then, of course, you always have to reassess. You want to make sure you do your vital signs. If it's at all possible to have a pulse ox available, it's very good to have a pulse ox in the room when you're doing this, because I promise you this, that will drop on you. But that's a good way of knowing how long you should wait between suctionings. This is what I do, especially on the pediatric community, because they're always on the monitor, at least on a pulse ox if they're not on the monitor. So you put the pulse ox on. If they're, 99 to 100%, you suction, you're going to see their sat drop. I wait until that saturation is back up to like 99% before I go down the second time. No, 15 seconds, 30 seconds, however long it takes.
What's a normal drop? Like, because you obviously don't want to drop too much. So what would be like an average of
Usually
what
it
it'll
drops
drop?
about 5, like to maybe 95, 90. I've seen it go down as low as 93.
Okay.
But there's no, everybody's going to be different. It depends on the severity of their disease process and just how much mucus they have.
So if the pulse ox goes really low, you should stop?
You should stop.
Okay.
If you see the pulse ox really, really dropping, and usually if you see the pulse ox really, really dropping, what's going to be going up?
Heart rate?
Your heart rate.
Yeah.
So you see right away that you're causing a problem here. Stop.
Stop.
Anything else? Okay.
And then you can take them off the non-rebreather.
Yeah, once they've you listen to your breath sound, you've checked their vital signs again, they look comfortable, their saturation is back up, take them off and put them back in whatever state they were in before you got there. If they were on a nasal cannula, put them back on the nasal cannula.
You were saying it's not preferred, but if they were on a nasal cannula and you moved it and you said you put both plugs in one nostril and you suction out of one side, how much would you increase their oxygen?
You can only go up to 40%, huh?
It's 5, didn't you?
5 or 6. Yeah, you can only go. Remember, even if you go to 6, you can only go.
Do you
up
leave
to
it in their nose while they're
44%.
suctioning?
What's
Yeah,
the
you
highest FiO2 you get with the nasal cannula?
40.
Oh God.
Oh, Jen's gonna be hurt, you guys.
Hold on.
Yeah.
Is it 48 or 52?
Not that high.
No.
What's the highest one?
Highest
Is
FiO2 you
40,
get with the nasal cannula.
24, 28,
36.
A little higher.
42?
About 44%.
Yeah, I'm
40.
counting. I'm counting the increase.
And trust me on this, you will have nurses all the time asking you how much about. I had a nurse call me. I have a patient on a venti mask, and he's on 50%, and the doctor wants to eat, and I have to put him on nasal cannula. How much should I put? They will ask you this all the time, so you really need to know that.
So you would leave the 2 in the one nose while you suction?
Suction on the other nostril.
Oh, because they had oxygen before, so you
Right,
can't
if
take
got
it
there,
off.
They were on a nasal cannula, but as your determination, you really don't want to put this person on a non-rebreather.
Yeah.
You think maybe the cannula is going to be sufficient to oxygenate them. It's a judgment call. You got to make a lot of judgment calls in this field. You get a lot of autonomy to make the decision for yourself what you're going to do and what you're not going to do. That's one of the things. The doctor doesn't tell you, the nurse doesn't tell you. It's your decision. Do you think this patient needs to go on a non-rebreather? Or can you just maybe jack up their FiO2 in the nasal cannula a little bit? Your call. Always your call. Okay. This guy has a trach. Tracheostomy, again, is a sterile procedure because the tracheostomy is a surgical procedure and it's going right into the trachea. So it's a direct line to the patient's airway. And keep it in mind, I'm going to decannulate this guy for a second. diastomy is only that long. So you're not going to be going down as far as you did with the nasal. It's only going in this far. So that's as far as you need to go with your suction catheter. Everything that we just did applied. Even more so now because it is a direct line. Now, as you can see, your patient is on an aerosol. And depending on what FiO2 he's on over there, you're going to jack up the FiO2 to 100%. How would you do that with this device?
The orange.
Turn the orange knob.
Right, turn the orange knob and get him to 100%. And you're going to let him breathe 100% for a while. Now, some of these patients will be coherent. So you're going to tell them what you're doing and why you're doing it. If they've had a trach for a while, then they have been suctioned before. Some of them will be kind of comatose. It depends. You have to, again, maintain your sterile fill. Again, you're going to determine which is your clean hand, which is your dirty hand. Make sure your FiO2 is on. Make sure your suction is on. Now, this is a case where sometimes I will have on 2 pair gloves. I will put a pair unsterile gloves on under my sterile gloves in the hospital setting. Like, again, it's a judgment call, especially if the patient has a lot of guncus and you're going to have to be doing a lot of cleaning. I might put on a pair of unsterile gloves and then put my sterile gloves on over them.
Is that a made-up word?
What?
Guncus.
You hear a lot of made-up words in the hospital.
Oh, that was definitely funny.
You're simply going to move your, what is that called?
Collar.
Tray
Straight
collar.
collar. Again, without applying suction, you're going to go in until you feel resistance. When you hit resistance, you're going to stop because you're probably on the carina. Come back about 1/2 centimeter. That way you're not going to be applying negative pressure directly to the tissue. And apply intermittent suction as you're coming out. Immediately reoxygenate.
Same thing 3 times.
Okay, how much do you back up once you hit the resistance?
About
An inch.
about 1/2 centimeter.
Okay.
You only have to come up a little way, just to make sure you're not on the mucosa.
Okay.
That
Let
seems
your
a
patient-
lot easier.
Huh?
That seems a lot easier.
Let your
than
patient reoxygenate. Go in until you feel resistance. You're probably on the carina. Come back. Intermittent suction as you're coming out. And you can clean your catheter out. The same would apply if you want a sample. Now you would do the same thing with this guy over here. Let's say he just got intubated in the emergency room and you don't have your inline suction on yet because he's on the transport ventilator. You have to use that same sterile procedure to suction him that we just did with this guy. Okay. The problem here is with both of these, you have to make certain that your catheter is not too large. You're going down an artificial airway. This is the only way this patient has to breathe. This is his only opening to the atmosphere where he's breathing now. If you completely occlude that with the suction catheter, you're sucking out everything. You're not just sucking out mucus, you're sucking out air and everything.
So smaller the better.
So according to all of your every single one of your textbooks gives you a different formula to figure out what size suction catheter to use for a bypassed airway. I think the one that is in your check-off book is the easiest. I think Mosby's has one, Egan has one. No, this is no. Okay, yeah, the ET tube size, the second one in your check-off book, the ET size times 2 minus 2.
ET
That's the easiest one of the
size
three.
times 2 minus 2.
Right now.
I don't know, but I don't have my book.
I have it,
on that
yeah.
page. I was like looking for which page it was. And
Yeah, it's right here. As you see, there's 2 separate formulas in your checkoff book. There's a different formula in Egan and a different one again in Mosby. Use this one, it's the easiest one. Your ET tubes come in sizes like 6, 8, 10, 12. I'm sorry, slide it over here. You can can tell what the size of your ET tube is. It's written right on here. This is on the flange here, a 7.5 ET tube. And if you look on your tray, there should be a number.
6 DCT?
6. It's a size 6 tracheostomy. And this guy has it, I think it's a 7.5 ET tube. And if you don't see it on here, go look in the chart, because when the person intubated him, the size of that ET tube will be there, and it will also be on your ventilator flow sheets. You always want to take, this is a 7.5 times 2 would be
15.
minus 2.
13.
So then you would go to the next lowest size, so you would suction him with a
12.
size 12.
Because there's no 13. Right?
Yeah.
Huh?
There's no 13.
No, they usually, the suction catheters are usually in evens, 6, 8, 10, 12, okay. This is an inline suction. This stays in line all the time. It's still a sterile procedure, but you don't have to worry about sterile gloves here because it's inside this sheath. So you're going to have on your regular gloves. You just put on a pair of regular gloves with this, because you don't have to take this apart or take it out at any time. It's attached directly to your suction, and it stays attached. You have your thumb port here, and it stays locked. Now, I can't push it down right now. When you're getting ready to suction, you simply pull it up a little bit and turn it. Now I can apply suction. Okay?
So that tube's always attached?
It's always attached.
You always want to make sure it's locked.
Yeah, make sure it's always locked.
Not that they would roll over on it.
I have a question. What is it that they tape on the top of the bed? It looks like this, or like the inside of this, and they put it in a bag.
If
and
the
they
patient
tape,
has a trach, you have to always have another trach at the bedside
That-
just in case
oh,
they
that's-
get
oh, okay.
decannulated.
That's the one they tape on like on
There's
the head of the
also,
bed.
when they have a trach, when they do something called trach care, they have to clean it. They have to put a different cannula in there while they're cleaning to keep the patient on the ventilator. Okay. Now, always hold on to this tube. Don't ever let me see you doing this, because this thing is going through the vocal cords. You can cause trauma, you can cause damage to the mucosa, and you can decannulate them. You can accidentally extubate them. So you're always going to hold on to this tube. You're simply going to, as you're pulling back on the sheath, you're going to push the catheter in. Again, you're going to feel resistance. You stop, pull back about 0.5 centimeter. Now you're going to apply continual suction. Over there we were doing intermittent. That means you're going to hold it down and pull it out. There's a little black mark on your catheter here. You want to make sure that little black mark is on the outside. See the little black mark? It's right there. See it?
Yes.
If you leave it like that with the black mark on the inside, look what you're doing. You're setting up a resistance when the patient's trying to get a breath in the ventilator. You're putting an obstruction in the way here. So you make sure that it's back so that obstruction is not
behind the blue.
behind the blue.
And when you pull the suction out, do you have to do it really slow?
Well, again, we're talking 15 seconds.
Okay.
And you're going to be able to judge as you're suctioning how much gunkus you're getting out and how fast you're getting it
You
out.
just go in, hold down, and pull out.
Go down, pull back about 0.5 centimeter, press, pull out. Always holding on to this ET tube. Now, there is that whole controversial issue as to whether or not to instill saline when you're suctioning. Some therapists swear by it. Some therapists absolutely refuse to do it. The reason is they're saying by introducing saline, you're actually introducing more bacteria into the airway, which is absolutely true. And it's never been proven that putting saline in helps to really loosen the mucus one way or the other. The thing is, it does help to kind of, put a little extra moisture in there. Might help you get it out. One thing I forgot to mention when you're suctioning a patient, these machines all have a 100% button on them. Remember, we hyperoxygenated all of our previous patients. It's very important that you hyperoxygenate this person. They're probably been ventilated. The machine's giving them their breath, their volume, and their FiO2. You hit that 100% button before you start. You wait about 30 seconds for it to actually, get all the way through. This will give you 100% oxygen for 2 minutes. After 2 minutes, it will go back to whatever FiO2 the patient was on.
So you don't have to hit anything when you're done. It automatically defaults.
It automatically goes back. And if you're going to be working with the patient for longer than 2 minutes, you just hit it again.
Hit it again.
And it'll go back to 100%. What I like to do personally is I hit the button and then I hit the alarm silence. The reason I do that is because when you're suctioning the patient, you may be causing them to cough.
It'll
Their
set the
high
alarm.
pressure alarm's going to go off. If you're suctioning out, they're losing volume, your low volume. So your ventilator's going to be going crazy and making all kind of noises. If you hit the alarm silence, at least you're not going to be hearing the patient, the family, the nurses are not going to be listening to that constant beep beep while you're suctioning.
And then everyone gets excited.
Hit 100%, hit alarm silence. The other thing that I do is if I'm going to instill saline or if I'm going to instill anything, that's what this little port is for. You put your saline bullet in, advance the catheter a little bit so that the saline's going to follow the catheter down. So when I squeeze it, that saline's going to go down the tube. Then I'll come over here and I'll give a couple of manual breaths. By manual breaths, I'm making the machine give them an extra breath, and I'm actually just pushing things down in there to churn it up a little bit. And then I go ahead and suction.
Wouldn't putting the saline in there rinse whatever bacteria is harboring in there into the
Well, that's
airway?
why it's a controversial issue now.
Yeah.
As to whether or not you actually do it. I think most of your textbooks will tell you, some of your textbooks will tell you it's a judgment call, some of your textbooks will tell you absolutely do not do it.
Well, the port stays closed.
The port stays closed. But you have a lot of
But
stuff in
when
here.
you're suctioning, whatever you're pulling up, some might sit in here still and
Yeah,
cause
it
it.
will sit
So
in
for our
there.
checkoff, do you want us to do the saline?
Not necessarily, but I do want you, once you finish, you have to rinse the catheter.
Oh.
You're not going to leave all that mucus sitting in this catheter, and that again requires that you instill saline. But now you're going to squeeze, and you're going to
Suction
squeeze
at the
here.
same time.
You're going to squeeze the saline and squeeze the suction button at the same time. So, and as long as your thing is in the right position,
And that's when.
see how it's suctioning it out?
Yeah.
So it's rinsing all of that mucus that's
But
in the
this
catheter.
is like pulled all the way out, right? Not like
Yeah,
when
it's
you
pulled all the way out.
For
Yeah.
just rinsing it.
So you're going to be squeezing and squeezing so that you're suctioning all of that. You're getting all of that mucus that was in the catheter. You don't want to just leave it in there because
one
stuff's going to
enough?
be growing there.
Is one
Sometimes it takes two. And you'll see in the hospital sometimes they have these bullets that are about 3 times this size and hold 10 mils instead of 3 mils. And I usually prefer to use those, especially when I'm rinsing. Make sure you reclose this port. Make sure you lock this back. And please, you'll find nurses love to do this. You'll come in to do your vent check and you'll find that. They invariably leave. I'm always yelling at the nurses at mamas. Why do you leave that on there? Just take it off.
My
and
favorite
close it.
is when they leave this setup on the bedside.
They do that too.
Did you said lock the suction?
Yeah.
Yeah. Go back, reassess your patient again. Always, always, always assess, perform your skill, reassess, especially when you're suctioning. Make sure your ventilator settings are back to where they were before, because even though you hit the 100%, and even though it's going to go back to whatever FiO2 you had it on before, you're going to be getting high pressures because they're coughing, or you're going to be getting low volume. Make sure everything's back to normal. Make sure your patient's back to normal, your ventilator, before you walk away. If you want to get, can I have that sample? If you want to get a sample from this patient, this still goes on here, and this now goes on here. Okay, so now you can get a sample into your container. You can get yourself a nice sputum sample. I would remove the suction side first, otherwise you can get your sample suctioned up into the cup. Reattach, and then just put this over and label it appropriately and send it to the lab in a biohazard bag. I always put these things in a biohazard bag.
That's it?
That's it for suctioning, unless you have a question.